Thanks very much for the introduction. As Colin said, I'm one of the clinical scientists at the West of Scotland Specialist Virology Centre in Glasgow. And my main role is the development, validation and implementation of molecular assays. So we're very happy when SpeeDx approached us to take a look at their new PlexPCR VHS assay. And today I'm just going to talk a little bit about the importance of molecular testing in syphilis diagnosis. So syphilis is one of those diseases which doesn't really need much of an introduction. It's an ancient disease which has been around, first documented in the late 1400s, and is likely to have been brought to Europe when Christopher Columbus returned from the New World. And it quickly spread and became epidemic across the whole of Europe, causing high mortality and morbidity for centuries. And there's even some suggestion that Mona Lisa's mysterious smile could be attributed to syphilis. With the development of penicillin for the treatment of syphilis, we were finally able to get a handle on the disease. And as you can see from the graph, between the 1940s and the 1950s, with this successful treatment, the number of cases of syphilis in the UK decreased rapidly. And they stayed low until the late 1990s, when we had near eradication of syphilis in the UK. Unfortunately, this didn't last very long, and at the beginning of the century, we saw an increase in cases again. And this has continued on an upward trajectory, and we now had a massive increase of over 1,000% in new cases in the UK over just a 17-year period. And the majority of cases are in the MSM population. And this has been attributed to an increase in unsafe sexual practices, which might be due to the improved treatments of HIV and the lowered risk of transmissions. And these increased cases haven't just been seen in the UK or just Western Europe, as cases of syphilis have been increasing in China, Australia, and North America. So, syphilis is caused by spirochete bacteria, Treponema pallidum. And after a few weeks after primary infection, a syphilitic chancre appears at the site of inoculation. This is a painless, indurated ulcer. However, primary ulcers can be atypical in presentation and sometimes can be misdiagnosed as HSV, LGV, chancroid, and also a variety of non-infectious causes. And they can present on the genital, oral, or rectal mucosa. 3 to 6 months after the primary lesion has spontaneously resolved, patients enter into the secondary stage of syphilis. And this is the result of the widespread multiplication and dissemination of the bacteria throughout the body. And patients present with low-grade fever, generalized lymphadenopathy, and a mucocutaneous rash with characteristic lesions present on the palms of the hands and soles of the feet. But again, the secondary rash of syphilis can present atypically and can be misdiagnosed as a variety of other rash illnesses. During primary and secondary syphilis, patients are highly infectious, but when the symptoms of secondary syphilis resolve, they enter into the latent stage of syphilis, and patients are no longer have no clinical symptoms of syphilis and are no longer infectious by the sexual route, at least. However, vertical transmissions still occur during the latent period. And the majority of patients will remain in the latent stage of syphilis for life. However, around a third of patients will then progress to the tertiary phase of syphilis. And this is the result of treponemes invading the CNS, the internal organs, skin, eyes, and bones. So we have a really successful treatment for syphilis with little resistance. And so diagnosing syphilis at the primary stage is really important to treat patients quickly and reduce transmissions. So there are two main types of diagnosis that we use. So that's the direct demonstration of the bacteria in lesions, and we also can use indirect methods of infection using syphilis serology. So the most commonly used method for detection of the bacteria in lesions is the use of dark field microscopy, and this involves the direct visualization of spirochetes in lesion fluid. And the samples need to be processed within around 20 minutes of collection, so dark field microscopy really has to be performed at point of care, and it requires experienced microscopists to review the slides. So dark field is usually only used in large sexual health clinics. It also has quite a low sensitivity, and it can't be used for oral lesions because the presence of commensal spirochetes in the oral cavity can cause false positives. The other method of direct detection is Syphilis PCR, which I'll go into in a bit more detail in a moment. The vast majority of syphilis diagnosis is done using serology, and there are a few different algorithms that can be used for serology, syphilis serology. The most commonly used, I think, is using a treponemal test as a screening assay, and then further confirmatory tests are required if a screening test is positive. And this is because there's lots of false positives in the screening assay, especially in populations with a low prevalence of syphilis, for example, in pregnant women. And as you can see from the graph, there's a few weeks period during primary syphilis where antibody response hasn't occurred, and there's no antibody produced yet, so there's a few weeks where syphilis serology would be negative. And this is the stage where molecular diagnosis of syphilis is really important, because patients could present with a chancre and be told that they're syphilis negative. So syphilis PCR has been described over the last 10 to 15 years, and real-time PCR for syphilis detection has been shown to be highly sensitive and specific in a multitude of studies. And unlike dark field, these PCR can be used for lesions from any site without a reduction in specificity. The majority of syphilis PCR is used for primary infection on primary lesions, but can also be used in secondary syphilis where lesions are present, although the sensitivity of PCR in secondary syphilis is lower due to a lower number of bacteria present in the lesions. And if you multiplex syphilis PCR with HSV, then you increase the diagnostic rates, especially in clinicians who aren't actually suspecting syphilis. And this happens quite often outside of the sexual health clinics. For example, we've had GPs sending samples to us for patients they think have got cold sore, and actually it's turned out to be syphilis. And we've had inpatients in our hospital who have complained of a recurrence of genital herpes, and it's actually turned out to be syphilis. And because we multiplex our tests together, you don't actually need a clinical suspicion of syphilis to get an accurate diagnosis. And furthermore, syphilis diagnosis by PCR is recommended by a number of guidelines, including BASH, NICE, and CDC. The primary recommendation for the European guidelines on syphilis management is the broader use of PCR, but we've still got a long way to go. ECDC did a survey of some reference and specialist laboratories performing syphilis diagnosis, and less than 1/3 of these laboratories actually performed PCR. And these are specialist labs, so as you can see, there's a lot of patients out there who don't have access to molecular diagnosis options. And the reason for this is there's been a lack of commercially available assays for detection of syphilis. So in Glasgow, we've been using syphilis PCR for over 10 years. We have a test that multiplexes HSV1, HSV2, syphilis, and an internal control. And we test all of our genital ulcer samples and any sample that comes from a sexual health clinic using this test. For our non-gun samples, these get a different multiplex, which has got HSV1, HSV2, and VZ. So when the samples arrive in our lab, we have to separate them down into these two streams, and they go and get two different tests. And all of our assays are in-house, so we make up the tests from the primer stocks directly, and all our tests are manually analysed on either the ABI or the light cycler. We performed a review of 5 years' worth of our samples that came in for HSV and syphilis testing. In total, we tested nearly 13,000 swabs. We found around 20% were positive for HSV1, nearly 20% were positive for HSV2, and we had 209 swabs that were positive for syphilis. 6% of these were negative when tested by serology, suggesting that if we hadn't been using PCR at this point, these patients might not have got a correct diagnosis of syphilis. And interestingly, 4% of our syphilis positive samples came from outside sexual health clinics, again reaffirming the need for molecular PCR available to all patients, not just those coming from sexual health clinics. So we're really lucky in Glasgow because we've got a big molecular team, and we have scientists who are very experienced in processing, analysing and troubleshooting in-house real-time PCR. But I realise that's not the norm, and the majority of labs don't have that ability. So the SpeeDx PlexPCR VHS assay is a 5-plex detecting HSV1, 2, VZ and syphilis and an internal control, and it's validated for both genital and non-genital ulcers, meaning samples don't have to be split at the beginning dependent on specimen sites. And commercial assays, especially ones that are CE marked, are much more attractive to laboratories because it improves quality assurance and is much better for laboratory accreditation. The SpeeDx assay also comes with an automated real-time PCR analysis tool called the Fast Finder, and this is a really easy to use software. And the majority of that analysis is done automatically, but the software does flag samples that need to be manually reviewed. So you do still need some experience with reading real-time PCR output to use this software, but it's a lot quicker than trying to analyse a whole run manually. And the test has a reported 100% sensitivity and specificity for syphilis detection. So in our lab, we use a method of verifying new assays based on the Public Health England guidelines. So we run tests to check for linearity, robustness, repeatability, analytical and clinical sensitivity and specificity. So we did these tests for the SpeeDx assay, and we showed that the assay was linear, robust and repeatable. To investigate the analytical specificity of the SpeeDx assay, we ran all of our molecular in-house real-time PCR controls, and these are pooled controls containing a total of 37 viruses and bacteria. And we got the majority of the results came out as expected. However, one pool that contained adenovirus, paraflu-1 and corona was positive for syphilis at a low level. So we went back and reviewed the trace from the Fast Finder software, and it didn't look real. However, the software hadn't actually flagged that sample as one to review, so had it not been a known negative, we wouldn't have gone back and had a look at that result. To look at the sensitivity, we ran duplicate dilution series through both our in-house assay and the SpeeDx test, and showed that the syphilis and VZ portion of the SpeeDx assay had equivalent sensitivities to our in-house test. And the HSV1 and HSV2 portion of the test was actually 1 to 2 logs more sensitive than our in-house assay. We also used an external quality assessment panel to investigate sensitivity and specificity. And we ran all these samples through our in-house assay and also the SpeeDx assay, and we got exactly the same results. When we got the report back from the external quality assessment scheme, we had missed, both assays had missed 2 low-level positive syphilis samples and 1 low-level positive VZ. And the report said that they had included 5 educational samples in their panel, and these are low-level positives that are really intended to test the assays to their limit of detection. So both assays detected the HSV1 and HSV2 educational samples, but we missed 2 syphilis and a VZ. But when we got the report, actually only a handful of labs had actually managed to detect the syphilis in this particular panel. We then looked at clinical sensitivity, and to do this we tested 250 clinical samples that had been tested routinely on our in-house PCR, and this comprised 50 samples that were positive for HSV1, 50 for HSV2, VZ and syphilis, and also included 50 negative swabs. So the SpeeDx assay detected 98% of our positive HSV1s and HSV2s, but it missed 2 strong positive VZ samples that came up at a CT of 13 and 14, and it also missed 2 low-level syphilis samples, given an overall sensitivity of between 96 and 98%. We re-extracted these discrepant samples and repeated them on our in-house assay, and when we repeated them, the HSV2 and the 2 syphilis low-level positives didn't come up again, so they were negative by our in-house test. And this isn't surprising because they're very low level and they come at the right at the end of our limit of detection. But what was more worrying was the strong VZ positives that were missed by the assay. So when we went back and reviewed the traces, you can see Texas red, which is this red line here, has come up really, really strongly positive at a CT of about 5. So it wasn't missed by the assay, it's just that the software hadn't detected it as positive. So we sent these results and traces back to SpeeDx, and they've used these traces to retrain the software so that it can detect these really strong positives. 4% of the panel had additional HSV1 detected that we didn't detect when we had tested the samples originally. And they were all at a low level. And I should just mention that the SpeeDx assay has a 10 cycles before it starts collecting data. So a CTA of 28 on the SpeeDx assay is equivalent to a CT of 38 on our in-house. So they are all low-level detections. So these false positive HSV1s were in different sample types, positive for HSV2, VZ, syphilis, and also some samples that had tested negative originally. So we re-extracted these discrepant samples and repeated them on both the in-house assay and also repeated them on the SpeeDx assay. And at this point, 4 of the 9 samples were then HSV negative, HSV1 negative, but one of them actually came up a low-level positive for HSV1 in our in-house assay, demonstrating that this actually was a genuine positive that SpeeDx detected and our assay actually missed the first time round. So there are a couple of possible explanations for this. They could be genuine HSV1 positives that the SpeeDx assay is detecting that our in-house assay is missing, because we know that the SpeeDx assay is more sensitive. For example, number 7 here, that's an example. However, we wouldn't expect to see quite so many dual positives, and especially VZ and HSV1 positives. Another alternative is that we might have low-level HSV1 contamination in the lab, either at the extraction stage or the setup, and perhaps we aren't seeing it routinely because our assay isn't sensitive. Or these could be genuine false positives generated by the SpeeDx assay or possibly generated at the analysis stage in the FastFinder software. So ideally, with these discrepant samples, we'll go back and use a third equally sensitive assay to try to clarify exactly what was happening here. And just to conclude, molecular detection of syphilis is crucial for early detection, especially in the primary stage of syphilis where serology might be negative. Syphilis PCR should be multiplexed with HSV so that even when there's not a clinical suspicion of syphilis, we can still get a diagnosis. And it should be available to those outside of specialist labs and sexual health clinics, and it should be available really to everybody. As I said, syphilis PCR is recommended in a number of guidelines, and now that there's a commercially available assay available, this should increase the the number of labs who are actually able to offer it. And the SpeeDx assay is sensitive and specific for the detection of syphilis in both genital and non-genital lesions, and that improves the streamlining of the test. And furthermore, the software allows non-specialist molecular sites to use this assay where they wouldn't be able to before. I'd just like to thank Simon from SpeeDx and Rory, who are involved in the project, and also a special thanks to Lauren, who performed a lot of the lab work as part of her project. Thank you very much.